breast cancer radiotherapy has changed quite a lot over the period of last many decades. If you look at the history of breast cancer, radiotherapy initially was not used. The primary treatment was surgery, and we were still having quite a lot of relapses in the breast area after the surgery. That is when the radiotherapy started being used. Now, once we started using radiotherapy, 60, 70 years ago, the incidence of local recurrences or incidence of cancer coming back in the breast and the chest area reduced significantly. And that is how radiation became an integral part of treatment of breast cancer to prevent local recurrences. But as time passed, we realized that something more sinister was happening. Patients who received radiotherapy were actually had a more chance of death. And I'm talking about, this is very old data. If you look at the data from 1950s to 1970s, and this was happening because the way the patients were treated. So what was happening is, these patients who were treated for radiotherapy for breast cancer, they were receiving quite a large dose of radiation to their heart, and this was causing cardiac problems, and these patients were dying of heart related problems. And that is why the radiation effectiveness was reducing. But now we are in the age where the radiation techniques have improved so much that the impact on the surrounding structures such as heart and lung, spinal cord, the other side breast has significantly gone down. So we are able to focus really very well on the breast tissue itself to make sure that we don't have, we reduce the chances of relapse, and also we don't have long term side effects. So, if you again look at the breast cancer treatment overall, almost all patients will need surgery. And the surgery can be either breast conservation surgery, where you don't remove the entire breast, or it could be mastectomy, where you completely remove the chest wall. Now, in all the patients who undergo breast conservation, we need to give radiotherapy because they have slightly higher chance of relapse. So we need to give radiation to ensure that we reduce that chance of relapse. And in chest wall patients, we give, patients who have had mastectomy, we give radiation only when the tumor was slightly larger in size, more than 5 centimeters. The side effects that we see nowadays are mainly limited to the skin. So the skin of the patient may become slightly sensitive, it may become a bit reddish, and sometimes even become a bit darker. If you look at patients who have very large breasts or have sagging breasts where there is a fold underneath the breast, they may actually land up having more side effects in terms of peeling of the skin as well. So, how do we, protect these patients from having these side effects? Is again using precision radiation techniques such as IGRT or VMAT, or rapid arc as we call it, and this will, make sure that we are focusing the radiation only to the area where it should go and not go to the surrounding structures. So, patient specific treatment is an absolute must going forward. So, earlier, what we were doing is we were using cookie cutters that, okay, for breast cancer, this is the treatment, this is how we will do the treatment. And we actually, when I started my training, we didn't even have the CT scanners and other technology to plan breast cancer. We used to actually do it either just with a pen, mark it on the patient's body and send them for treatment. If it was a chest wall patient, a mastectomy patient, and if it was a breast conservation patient, we used to take some x-rays and then plan the treatment. But that was not, that was not the most precise way or most customized way of doing the treatment. Now, in every patient, what we do is we do a CT scan for the patient and plan the treatment on that CT scan, looking at where are all the organs, where is the heart, where are the lungs, spinal cord, the opposite side breast, and then we are able to focus the treatment onto that area only. So, patient specific treatment is definitely an absolute must going forward. So, in clinical practice, the customization of the treatment is starts right at the time when the patient consults the doctor. So when the patient comes to me, I'm going to look at the patient's, all the treatment that they have undergone, the diagnosis, the staging, and then I have a matrix in my head that okay, and we have departmental protocols for that. So, for example, as I said, if it's a patient with a very early stage breast cancer has had surgery, we may offer them short course radiation. If it is a slightly advanced breast cancer radiotherapy, we may offer them the 20 course radiation. And then whether it is left side or right side also makes a difference. If it is a left side radiation, then we have to use that deep inspiratory breath hold radiotherapy technique to reduce the dose to the heart. If it is right side, we do a standard radiotherapy in free breathing, so the patient keeps breathing normally. So then, when the patient comes for radiation planning as such to our department, then we do a CT scan, and that CT scan then is imported into our treatment planning systems, and there we use the data of the previous scan. So we look at the patient's previous MRI, CT scan, PET scan, and we fuse those images with our radiation planning CT scan. On the basis of that, we then decide which areas to treat. So, for example, if the patient had lymph nodes in the axilla, we will not only treat the breast, but we will also treat lower part of the neck called the supraclavicular fossa. Or if the patient had lymph nodes to start with under the surface, under the breast, what we call as subpectoral lymph nodes, then we have to ensure that we cover that area as well. So using of the previous imaging data to customize the treatment for that patient is used, and then we create a plan, and then the treatment happens. Now once the treatment starts, then every at regular intervals the patient will meet the radiation oncologist, and they will evaluate what are the side effects that the patient is having, how is their arm movement, how is their diet. We'll see what the rehab team and the dermat team are advising, and we walk the patient through the treatment. So that is how we sort of customize and um, help the patient to get through with it.